So I'm going to get started here. Well, welcome everyone to the Washington State Telehealth Collaborative. I think what we're going to do first is acknowledge our host, Davis Wright Tremaine, and Miriam Swedlow is pinch hitting for Adam Romney. So Miriam, we'd just love to hear a little bit about Davis Wright Tremaine and kind of your guys' interest in telemedicine, and then we're going to move on and just do introductions and dive into the order of business today. So Miriam, take it away.
Turn my speaker on so everyone can hear me. Hello, I'm Miriam Swedlow, and Davis Wright Tremaine is. We're very fortunate to be a big enough firm that we have a broad range of experience in many different topics as a firm. So that doesn't just include healthcare regulatory issues. It also spans to privacy and security, IP protection, as well as transactions and business and corporate transactions. And within that broad experience, we can then create focused teams that better service our clients in specialized markets. And in our digital health spectrum, we've been able to work with innovators that include big data and data analytics, medical devices and robotics, wearables, Internet of Things, and of course, telehealth. And within this spectrum of telehealth, we as a firm have worked with clients both servicing direct to consumer telehealth services, as well as hospital to hospital telehealth services. So those are telehealth, or telestroke, tele-ICU. We also have worked with clients on credentialing providers for telemedicine services and helping to create telehealth apps for wearables and other tablet devices and things like that. And then, of course, finally negotiating contracts in terms of payment and compensation for providers and companies who are working in the telehealth sphere. So, on a practice level, we find this to be kind of the future of where medicine is going. It offers so many things, and as a firm, we're able to kind of pull in lots of different aspects of our skill and kind of help our clients to kind of create this next frontier. So we're excited about it.
Great, thanks, Miriam. And I think you have the nicest view we've ever had in this collaborative meeting.
We are, and it's going to be lost, sadly. So as this building is coming up,
you have to take advantage of it.
Encroaching upon it.
Yeah. So for folks who are joining us, you're missing out on a world-class view of Puget Sound. Why don't we continue with introductions and. Chad, I know this is your first time here on the collaborative, so if you wouldn't mind just giving us a little bit more than a normal introduction, just your background and of course, who you work for.
Thanks so much. So Chad Gabeline, I'm currently with Virginia Mason. I just started with them as their director over telehealth as well as the Stroke Center. I used to work with Denny Lorden at Providence Telehealth, and then before that, I worked with several folks that Denny's familiar with at Swedish on their telehealth team too. So I'm kind of in a wide variety of roles, everything from implementation, program development, and several other things. I'm a nurse by background, obviously. I'm a local yokel, so I've been around for quite a while, except for a couple of stints in California. I think that was just to get the rust off, and then I'm back here again. So grateful to be with this team. Looks like a great bunch of folks. I'm very excited about what I can contribute here. So.
Thanks, Chad. I love your pin that you got.
Yes, actually, that was from the ATA. So I was trying to. I actually got about 10 of them. So it's good. It's good.
Senator Becker.
Okay, I'm Senator Randy Becker, and I represent the 2nd Legislative District. And I am a local yokel. I grew up in Enumclaw, but I live in Eatonville area. And this is what our third year yeah. On the collaborative, and I'm excited about the potential that we have in Washington State with what we're doing here. So,
Priscilla McGraw. I am with UW. I am Dr. Scott's right hand, and literally the collaborative coordinator.
Great, thanks, Priscilla. John Scott. I'm the infectious disease doctor by training and help direct the telehealth program at the University of Washington, and privileged to chair the collaborative.
Hi, good morning. I'm Sarah Orth, currently with Seattle Children's as their telehealth program manager, but I have a lot of experience with this kind of thing. I started my career in the state of Maryland, where I ran the telemedicine task force there for 4 years. So kind of the same thing. I'm happy to be back into some policy.
Yeah, and Sarah's going to be talking to us a little bit of her experience in Maryland later today. So.
Great. Hi, I'm Jenny Cruz. I'm a medical oncologist and the medical director for the network and community sites for Seattle Cancer Care Alliance. Previously, I was at Peace Health where I had a telehealth, teleoncology clinic with some of our sites, and now I'm working with John and his team. We're doing a pilot with an SSCA through our network to offer teleoncology. Happy to be here as a guest.
Hi, good morning. My name is Joelle Fatih, and I'm the former program director of telehealth programs at Swedish Medical Center, currently in the role as director of nursing practice and health policy at the Washington State Nurses Association. I'm a nurse and a nurse practitioner, and I'm also on the American Nurses Association Telehealth Connected Health Steering Committee. We're currently ironing out some principles that are sorely in need of updating.
Representative Joe Schmick, I represent the 9th District, and I know all of you know where that's at. So, but just for those who don't, southern part of Spokane County, Whitman, Adams, Asotin, Garfield, and most of Franklin County. I'm a ranking member for the House Republicans on the Healthcare Committee.
Hi, I'm John Bose. I'm the Health Services Analysis Operations Manager at Labor and Industries. This is my first meeting, so I'm joining the group and in a representative role for LNI. I come from a background of having worked at Virginia Mason for 10 years. I put together their spine clinic program that with Dr. Mecklenburg. I went over to Group Health for a few years and then decided I didn't actually want to be a lawyer, after law school, and became a consultant for the VA and traveled about for a couple of years working on various things, including some telehealth.
Very diverse background. Okay.
Good morning, I'm Denny Lorden. I'm the telemedicine program coordinator for Providence St. Joseph Health, and I'm over in Representative Schmick's neck of the woods. And I also chair the Telehealth Advocacy Council for our system-wide program.
Thanks. Let's go to the phone and video, and I see Brody DeChinko. Brody, just want to say hi, and we got a couple new people today. Brody, if you wouldn't mind just introducing yourself to the new people.
My voice coming across clearly?
Yeah, go ahead.
Great. Hi, everyone. This is Brody DeChinko. I'm normally in Seattle, but today calling in from Portland, Oregon. I'm the general manager for convenient care delivery at Cambia, which includes the region's Blue Shield plan.
Great. Thanks, Brody. Other people on the phone who want to say hi.
Good morning. I'm Thea Mounts. I'm the program director for the Washington All-Payer Claims Database at the Office of Financial Management. And the Washington APCD was called out in Senate Bill 6399 as a potential source for evaluating the telemedicine pilot.
Great. Thanks, Thea. Glad you could join us, and we'll look forward to hearing more about the All Claims Payer database next time. And also just want to quickly introduce my colleague, Leah Rosen, who is one of our project managers at the University of Washington, an expert on e-consult. Are there other people on the phone who wanted to say hi?
Yes, this is Leslie.
Hi, this is Tracy Drake.
I heard Leslie.
This is Tracy Drake from the Department of Health, Health Professionals.
Tracy Gray, thank you.
This is I heard Sean Axelvan from Medical Director for Imera Group.
Good morning, Sean. Thanks for joining. I think I heard Leslie Emmerich. Is that right?
Yes, I'm here representing the Washington State Hospice and Palliative Care Organization, the Home Care Association of Washington, and ARMPs United of Washington.
Thanks, Leslie. Other folks on the phone?
Hi, this is Lisa Roach with Providence St. Joseph.
Hi, Lisa. had another person that.
Joe Smecker, I'm Director of Operations with Western Washington Medical Group. We're a multi-specialty medical group in Snohomish County, and I'm just interested in seeing where telehealth is in Washington State as a potential service extension for our group.
Joe, what is your last name again? I just didn't quite catch that.
Smecker, Smecker.
Okay, thanks, Joe.
Hi, this is Cara Towell calling in from the University of Washington. I'm with the Department of Psychiatry, and today I'm kind of practicing telemedicine as we speak. I'm sitting here in one of the hospital rooms with a parent who is recovering from surgery, so I can attend to excellent care at the University of Washington, and I'll be in and out during the conference.
Okay, thanks, Cara.
And Hi, this is Sheila Green-Shook, representing the Washington State Health Information Management Association.
Sheila Green-Shook, thank you. Sheila.
This is Sharon Lindsay. I am at Seattle Children's Hospital in the Quality and Safety Program Manager.
Great, thanks, Sharon. We have your colleague here too as well.
Which one is that?
Sarah Orth, sitting right next to me.
Oh yeah, hi Sarah. Hi. Wonderful. Hi Sarah.
Good. I think we have some other people who wanted to say hi.
Yeah, this is Stephanie Shushan, Senior Analyst for New Programs Integration at Community Health Plan of Washington.
Stephanie, glad you could join us.
Yeah.
This is Cheryl Huchala, Provider Contracting Manager at Primera Blue Cross.
Great, thanks, Cheryl.
Hi, can you hear me?
Yeah, go ahead.
Oh, okay, hi, my name is Andrea Kelso. I am the staff attorney at Washington Autism Alliance and Advocacy.
Andrea, did I hear you're with Autism Alliance?
Washington Autism Alliance and Advocacy.
Okay, great.
Yeah, thank you for having me.
Good. Yeah. Any other collaborative members who want to say hi? Sue Stern or Dr. Jimenez? Senator Cleveland, Representative Bergquist. Okay. Great. Anyone else from the public who wants to say hi? Okay. Well, great. So if you're not talking, if you could just mute your mic. I know sometimes there can be background noise. And if you can also type in questions. I see those under the chat function. And there will be a public comment period at the end. So just let you know how things are running. You should be able to see the agenda. We're going to go over the last meeting minutes, and then I'm going to do a brief update of the American Telemedicine meeting, and really the bulk of our time is going to be talking about payment parity and a guidance report for the rest of our time here. So let me move on over to the minutes. And those should have been sent out ahead of time. If you haven't had a chance to review them, I'm just going to pull those up. And just a thanks again to Adam Romney, who reviewed a lot of the malpractice last time. So I'm just going to let people review this, see if there are maybe edits, comments on that. You need a motion to accept. We'll let people have time to review. But yeah, if there is a motion to accept this, we can move to that. So, okay, do we have a second?
Second.
Thank you. Thank you. Great. Discussion? Any edits, comments? Okay, all in favor of approving the minutes and posting them to the website, say aye.
Aye.
Aye. Any in disagreement? Okay. Well, great. Let's put those up on the website, and we can move on to the next order of business. So I'm going to talk about the ATA meeting, which was in Chicago last Sunday through Tuesday. Chad, you were there. Denny, you were there. I don't think, Carl, you weren't there this year, were you? I didn't. If you were, I didn't see you.
I was not, actually. I was not.
Okay. So it was a smaller meeting than previous meetings. It was around 4,700 attendees, where it's been as high as almost 10,000. And there were probably fewer vendors as well. So in general, I think it had a little bit lower kind of an energy than in prior meetings. and we can talk about maybe why that is. But I think maybe the biggest news was really a lot of the announcements of mergers that happened. So some of you may not have seen this, that Carina, which merged with Avizia last fall, announced that it is now merging with one of the largest telemedicine providers, American Well. So this is going to be a truly national company that does hardware and software. That's a pretty big deal. And also on the same day, another merger was announced, InTouch, which is a company that I think, Denny, you're familiar with, having worked with them. They're the ones that had the robots, and really had a lot of telestroke. They are merging with another hardware provider, in Reach, based out of Georgia. So some really big announcements, and I think what you're seeing overall is a consolidation of telemedicine, just like we're seeing consolidation in other healthcare industries. And maybe that's why there's fewer vendors in general. So what I wanted to do is just go over some of the slides from the plenary session. It was from Dr. Lisa Bielamovich. I don't know if I said her last name right. She used to be the chief medical officer for the advisory board. She has started her own company but really still is coming from that background from advisory board. And I thought she presented a really good overview of the healthcare system, some of the challenges we're facing, and then laid out where does telemedicine kind of fit in this huge puzzle. So I'm just going to go through that if that's okay. So the first thing that she laid out was really kind of the policy landscape. And I think all of you know that we had lots of healthcare legislation to repeal and replace Obamacare ultimately did not happen. However, tax reform did happen. And that's ultimately going to play a role in healthcare because the fiscal impact is really going to be felt in the coming years as the cost of entitlement programs, Medicare and Medicaid, start to increase. So just a quote here from Paul Ryan, that we'll spend more time on the healthcare entitlements because that's really where the problem lies, fiscally speaking. So I thought that was interesting that we're not done yet with that. And just to kind of give you an idea of how we spend money in this country, as the presenter said, is we basically our monies go to entitlement programs and a large standing army. And the greatest increase in that expenditure is Medicare and Medicaid, and you can kind of see how it's expected to increase here over the next decade or so. So then breaking it down, how do we expend that money? Drugs is about 15-20% here. Payers is another big chunk, but providers are a really sizable chunk here. And speaking from a Washington, D.C. perspective, she said that the providers really don't have as much clout because there are fewer of us. We're not as consolidated. The AMA does not have quite the power. And it's a very confusing cottage industry with thousands of providers with all of their own agendas. So her point was that when it comes to legislation, a lot of times the providers are kind of holding the bag, so to speak.
May I ask you a question on
Yeah.
that slide?
Yeah.
When you're saying providers, are you saying actual providers, or are you saying in general the healthcare expenditure system?
Health system and MDs, ARMPs, yes.
But not hospitals.
Hospitals would be included in this.
Included,
Yep,
okay,
yep,
thank
yep, yep. So the other kind of major driving force here is just demographics. I think everyone knows that the baby boomers have started to retire. And when Medicare was started in the 60s, the number of working people to retired people was much greater. And even with the millennials and their population, there are fewer working people supporting more retired people. And this is just a demographic that we're not going to be able to change anytime soon. So the other thing that's going on is that margins for hospitals are really starting to get squeezed. So in 2016, the mean hospital margin was just a little bit under 3%. And with current trends, whether it's in payer mix, whether it's in just the baby boomers and more people on Medicare, it's expected that the mean margin is going to be negative. And in fact, I think it was 60% of hospitals are going to be in the red in the next 5 to 10 years. So a big kind of wake-up call on that. So this is just another slide showing that the providers are increasingly going to have to be responsible for that. It's a combination of some of the power dynamics in DC, but also what we call the high deductible health plans, that more and more patients are getting these bronze plans, and they are getting, be more responsible for that. So they're going to be increasingly choosy on their health care. So I'll skip that. Just a little bit of a note about Medicare Advantage and some of the hospitals' forays into accountable care organizations. What you can see is the vast majority of them are still in track one, and that a lot of them are kind of getting out of the ACO business. They're just not willing to take on risk. They're just scared, quite honestly. Let's skip here. So I'm sure as the legislators are in attendance today can say is that a lot of the spending for Medicaid is being pushed to the state. And we're seeing this in the form of block grants like the 1115 waiver and through more managed Medicaid programs. So that's also another burden that's being felt on the state level. So we talked a lot about the entitlement programs, Medicare and Medicaid, but at the same time, we're seeing that employers are also trying to reduce their healthcare costs. And it's kind of like 20 years ago, a lot of employers were offering pension programs, and then they started switching people to 403Bs and kind of funding their own retirement. Seeing the same thing here is and instead of just providing the healthcare insurance, they're asking their own employees and the patients ultimately to kind of figure it out. So you can see that the average cost of insurance is going up, and a lot of that is being shifted to the individual patient. So this is just a defined contribution is really the end game. So the last couple slides here that I want to end with is that we're going to see more and more patients being choosy and about their healthcare experience. And this is where telemedicine I think plays a role is really understand the value proposition for healthcare, that you're going to see more and more people questioning whether they should go to urgent care or the emergency department. And telemedicine often is a great way to start that and the triage. I think some of you have heard about things in the news about patients who are being expected to understand what is a reasonable reason to go to the emergency department. Like there's all these lists of things, and I think that sometimes it's not always clear. And maybe the telemedicine is a good place for them to help understand, is this something that can wait, or should they go to the emergency department? So speaking as a physician, I think we do a very bad job understanding what's important to patients. I think we very, very much focus on quality of care outcomes. And I think that most patients have an expectation that we're delivering a high quality of care. But things like convenience and how the doctor interacts with them are maybe not as well appreciated. And again, telemedicine can help deliver that kind of convenience and also the speed of the visit. So it's called Awakening the Sleeping Giant, the American Consumer. We'll just maybe stop right there just to highlight that there's lots of other mergers that are going on. So that's what I thought was interesting from the ATA. Danny or Chad, any other things that you wanted to highlight that also stuck out to you and would be helpful for folks to hear about?
I thought it was pretty interesting. Our association is going through a major change right now and realignment. There's been a lot of turnover. There's a lot of shift in focus. And I think, quite honestly, it's a healthy step back to revisit what we're doing and how we're doing it. As Dr. Scott said, I think a lot of the reason that telehealth is now becoming widely adopted is because of the millennials and the company mergers and things like that, and it's just being forced. And now we have other people out there pushing the envelope and advocating and getting these things done. I quite honestly didn't have a chance to attend as many of the sessions to hear about clinical programs because we were involved in so many discussions about advocacy, and it's becoming pretty prevalent across the special interest groups, the SIGs. It's not that the barriers have gone away, we're just trying to pay more attention to those. So now we're dealing with the interstate licensure compacts and reimbursement, and you name it, they're still there. But now it seems like we have more momentum behind us to address some of these things. So it was a pretty interesting conference.
Great. Chad, anything, any other talks or?
Unfortunately, like Denny, we were a little caught off guard by some of our vendors affiliating. So I was unfortunately attending a few meetings because of that, unexpectedly. But you know, kind of as Denny's characterized it, there was some good lectures on the interstate challenges that a lot of us are trying to face in doing business outside of our local region and so forth. So. But I didn't glean anything super new from the conference either. So that's about it.
Priscilla had included some slides also from some folks that presented on disaster preparedness. I went to at least 2 different talks on that. I know that in the past there have been people who have been interested to understand how telemedicine can meet that demand. With the large hurricanes we had last year, there was quite a bit of telemedicine that was deployed. So the slides are from Dallas, where there's a mega that was set up, and there was telemedicine built in. I don't know if it's funny, but there really wasn't much use for telemedicine just because the on-site care was really good, and people were able to get resettled very quickly. So I think that the learning point from that is that it's an adjunct to a normal health system, and you know, if the regular health system is functioning well and can absorb it, then it's more of a safety valve than anything else. Yeah. Okay. Any questions or comments from
that slide deck that you showed us there? Is that in our packet that you sent?
And did you send it out?
No, you didn't.
Okay, sorry, I sent the wrong. Okay, I can share this because this is public knowledge. Yeah. Yeah, it's pretty dense. So there's about 50 slides, and you know, she used to be the ad board, so if you are familiar with it, it's very much that format. So yeah, I'm happy to share those. Good. All right. Well, why don't we dive into the next topic of discussion, and that's the payment parity bill. Denny, do you want to kind of kick off the discussion, and then we can turn to Sarah and her experience, and then we'll spend most of our time talking about that.
So I had a chance while at the ATA meeting to meet Latoya Thomas. She's the Director of State Policy Research Center. Oops, I'm sorry. And what I wanted to do was I forwarded our bill for her to have a look at before we met, and to kind of compare it to the 2 states, Minnesota and Hawaii, that already have parity bills in place. Because I wanted to get her sense on how she thought it was crafted. And she said a couple of things that were pretty enlightening. She said on the good side of things, this would be an excellent source of data for the feds, because data is severely lacking as we try and, push CMS to adopt additional codes and things like that. She said it would be very helpful in those discussions as well. She thought that the challenges were probably related to the length of the pilot, 3 to 5 years, and whether or not we'd be locked in by that, and also the associated data collection would be challenging, but I think we all knew that. And especially when we're trying to justify whether there were associated cost savings and things like that. And I think there was also some mention of fraud in there and increased utilization, which I think the payers would be also very concerned about. She said her recommendations would be very clear as to the outcomes that you're desiring on this pilot, and you try and stick to those. If we track the denials, the idea there would be to debunk the argument that it leads to increased utilization. So that's what we're trying to do as well. Diversify the population mix to make sure we get adequate numbers to substantiate our argument to the folks that we need to. Be very aware of the secondary impact. In other words, a population for a service might grow utilization of other related services. And I thought this one was really good. Be cognizant of the impact to patients over time, such as pediatric telepsychiatry patients that are able to return to school earlier and function better. Occupational medicine, integrated behavioral health patients returning to work earlier. And reduction in travel expenses that we typically see in the Medicaid population, which is pretty significant if you're watching that. She said you also might consider waivers as another mechanism for trying things, and I think those are largely geographic barrier. Yeah, right.
So we could do a 1332 waiver, so it wouldn't cover everyone, not just Medicaid, because the 1115 would be just Medicaid.
Okay, and we're talking in our group at Providence and looking into waivers more significantly as well. And one of the things I wanted to ask you, Senator Becker and Representative Schmick, is she said one of the things you might consider is what North Dakota did. And this is along the notion of carving out a specific area in contrast to picking 5 clinical services as a pilot. So what North Dakota did, and I'll just give you a brief excerpt from the language, payment or reimbursement of expenses for covered health services delivered by means of telemedicine under this section may be established through negotiations conducted by the insurer as the same manner for face-to-face services. So I think a lot of our opposition came from the teledoc, the virtual primary care visits, and that kind of threatened their online standard fee model. But I think they were the primary folks that had issue with that, correct? So if there were a way to carve those out and still allow for a negotiated rate with a carrier, but everything else was somewhat protected, is that reasonable, or did you pick 5 services for a reason?
No, it was a starting point.
Okay.
And because of the short session and how many bills that we had actually presented, you didn't know what was coming and actually going to move forward. Did you feel the same way, Joe? I mean, there were double the amount of bills in a short session as in history this last year. And so, for example, in healthcare, I mean, we had all sorts of just outlandish bills, but we didn't know what ones we might be working on. So that was the dilemma. This being a longer session, and us, if we start writing the bill and working with everybody just earlier than we got to last year, it'll be a lot better.
Okay.
Yeah.
Well, you probably have much more experience in whether or not that model might work, but just wanted to throw that out.
I'm open to anything on trying to get people to at least look at it. The other thing that I thought about, Denny, was tying it to Medicare as Medicare approves different payment methodologies, and then it would just automatically roll over into the carriers, et cetera, and to see what they thought about that.
Okay.
On a very practical standpoint, when you talk about tracking data, unless we do it, like Senator Becker suggested, unless we do it such as in Medicaid in our state, where they have a central place where they can track data. If this gets out into the private sector, how do we track that data? I mean, you've got 3 carriers. They're not going to want to share. I understand what you're after overall. I'm from just a practical standpoint. How would we make that work?
To go back to the practicality of that, Joe, is we have the all-payer claims database. And the all-payer claims database.
See, you believe that that's really going to work.
Yeah, I do.
I have my doubts. Because if you don't get all the data in,
well, it's a requirement in the state of Washington. That
I know.
So one of the challenges that we're facing right now is we're really struggling to try and find out compliance with the new parity law. And I think there's a large variation in the coding mechanisms and
I apologize if I'm interrupting anyone. There's no audio.
I'm sorry, that's Senator Becker didn't push her button. But anyway, I do believe that one service could initiate more services, different services, but they're probably needed services today. We just don't recognize that they're needed as easily.
I
So
would imagine those indirect or related costs are going to be even harder to track. So we're going to need a source that can, pardon me, I was stating that those indirect services or related services might be even more difficult to track. And the things like, are they returning to work sooner or things like that. I know it could be done, but we'd almost have to have our own analyst pulling this data.
Danny, going back to the ATA and your conversation with LaToya Thomas, has the ATA kind of looked at some of these, or do they have a repository of cost effectiveness studies that maybe we can look at? I recall seeing a library or something like that.
I think there are, because one of the comments you made was it's fairly easy to debunk the notion of increased utilization. There have been some studies, and so I'm thinking that they're there. We just need to ask.
At the ATA session, you guys might recall last summer there was a study that came out from the University of Wisconsin showing direct-to-consumer telemedicine for urgent care, primary care services increases costs and utilization because now these people are paying cash up front and then actually getting into the health system. So the University of Pennsylvania Medical Center, UPMC, they had this program for telehealth, and they were thinking, hey, that's not what we're seeing. So they did their own study, and it was the most comprehensive, data-driven study that I've seen. I can send those slides to you to send out to the group. But same thing, they looked at everything from cost to antibiotic prescription rates in the ED versus video visits versus urgent care and primary care, and they were the same across the board, which leads to the bigger question of why are antibiotic prescribing rates so high, but that's a different discussion for another day. But they were consistently high, so plus or minus 1%. So there are some studies out there, but you can pick up one study that shows you one thing and another that shows another, so it's all just kind of still evolving.
But Sarah, that goes back then to Dr. Scott's comment about we don't do a good job of treating them people as customers in a sense. And the telemedicine, if you're getting the same results and the same cost, and you're actually making it so people from Eatonville want to talk to somebody at the U, then it's a benefit. So it goes back to that part of it as well.
Mm-hmm. Absolutely.
Francis.
I just would want to make a couple comments. So I totally agree with that, and with the studies that are out there. We've been at Molino, so we've had our virtual urgent care program. So again, direct access to urgent care, primary care for now several years. And again, this is a free service to our Medicaid members, so we don't charge anything, of course. And so you would think that unfettered access might drive significant utilization. On the flip side, we want people to come in. We're begging our patients to come in because of the transportation issues and other things that are so difficult and challenging for them to access the primary care docs. We have found that it has not been abused at all. And I'd say that the rate of individuals who have more than one visit is about 20%. And we want them to do it. I'd much rather have high ED utilizers use this service than running into the emergency room all the time. And so we're actually marketing this program into that population to drive utilization within that cohort. And so, we're kind of doing the opposite. The other thing we're seeing is we're integrated, behavioral physical health in a couple of regions in the state. And what we're seeing there is, absolutely right, you do drive utilization when you start to treat patients with mental health disorders. But, you cannot get them to pay attention to their diabetes or care about their hypertension until their mental health issues are stabilized. And so I welcome that ability to be able to, yes, we're going to pay more for their primary care, we're going to pay more for their medications, but they're using them, taking them. And it keeps them out of the hospital, out of the inpatient, visits go down. And we've seen that our ED utilization among that integrated cohort has dropped significantly. So outpatients gone up, inpatients has come down. So that's
So you've
really where we want to be.
documented the transition from ED to virtual.
Yeah.
Oh, wow.
Yeah.
So costs are down.
Costs are starting to go down. It's a tipping point. It just takes a while. And a lot of it is if people don't know that it exists, they will never, they won't access it.
Yeah.
So our challenge is marketing,
Yeah.
And really marketing and making sure that they're aware that it's out there and what it's used for. But our antibiotic prescribing rate's about 11% for those who get antibiotics. Super low.
Well, 11%.
Yeah,
Wow.
really, really low.
Was it in
69% at UPMC.
Yeah, so outpatient, we often look at like bronchitis, and that's usually around 60% if you're seeing a doctor in the clinic. I'll just tell you what ours is at, since we have a virtual clinic, it's around 40%. We use like virtual practice guidelines and everything, so it's still too high, but 11% is really low.
For antimicrobials, overall it's about 30%.
Yeah, that's great. I just want to open it up for comments from folks who are joining on the phone or by video.
This is Brody from Regents. Just like the previous comment, our challenges on the utilization front as well. We have less than 1% of our members using a telehealth visit during the course of the year, which is well below what I would target as what we would like to see. From just, I guess, an induced demand perspective, we don't really have too many concerns from what we're seeing in our numbers. From where we stand, we believe that 4 out of every 5 telehealth visits is replacing an in-person visit, and 1 out of 5 is being induced, which my perspective is reasonable. And we've also done some claims analysis to determine that within 7 days after a telehealth visit, in 95% of the cases, we are not seeing an in-person visit anywhere for the same diagnosis. And so from a resolution rate, we seem fairly satisfied with that as well. So, but our biggest challenge right now is awareness and utilization. We're pouring a lot of efforts into letting people know that they have the benefit. In 2018, we reduced our co-pays for virtual care to be lower than the in-person rate, but yet still with that, we're still kind of at a pretty low utilization rate. So we're trying to crack that nut.
Great, thanks. Just for folks who maybe, I think we lost some audio for about 5 minutes. So I wanted to highlight what Dr. Frances Guff said. She's the Chief Medical Officer from Molina, and she was saying that they have a direct-to-consumer product that has not been abused. I think it's a safe comment there, and they're really trying to market it more. They're trying to get people out of the emergency department, and they've seen a real shift from fewer inpatient costs, so that's ED and inpatient hospitalizations, but one of the reasons for that is that there's more outpatient costs and more pharmacy. These people who are maybe are depressed or don't have their mental health are now getting those taken advantage of. So I just wanted to make sure that folks heard that really important comment. And we'll have the minutes to describe Denny's very insightful conversation with the ATA.
Did you want to talk about the codes?
Let's put a pause on that because I want to continue with this conversation about cost savings and things like that. And I'm going to turn it over to Sarah Orth. So as some of you may have heard, Sarah has a lot of experience with this in another state, in Maryland. And so I'm going to pull up your slides, Sarah. And once Sarah is done, Brody, I just want to come back to you and ask you about maybe the experiences with the Blue Cross Blue Shield programs in the 3 states that have passed parity. So it's Hawaii, Minnesota, and Delaware. I think you had done a little bit of investigating on that. So just to prep you on that, Brody. So let me pull up your, which one is it? Is it this one? This one? Yep. There it is. Okay. Okay, great.
Thanks. So I've been with Seattle Children's only since February, and prior to that I was with the University of Wisconsin Health System in the same role. And previous to that, I was a regulator in the state of Maryland. So I oversaw health information technology, which included telemedicine and the telemedicine task force that was legislatively mandated. Two of our key accomplishments were getting the parity law passed in 2013. So I helped write that language for that law, and then also the subsequent Medicaid regulations that went along with that. We'll get into that in the slides in a little bit, but just wanted to let you know kind of that's the background of where I'm coming from and how this is tailored for today. So I wanted to give you a quick update on the current state of payment parity laws across the nation. Quick note about the slides. I want them to be a resource for you. I'm not going to go through every single thing on every single slide, but you can come back to them when you need them. And since the payment parity landscape is changing so quickly, I thought we'd just do a quick baseline of where we're at, and then talk about what is this collaborative charged with in the bill, so we all have a baseline refresher on that. What does this store and forward specifically landscape look like across the nation, and then a little bit about what we did in Maryland, and then how the options for this collaborative to think about moving forward and designing the pilot program. Next, starting with the parity laws. So key policy considerations, most of this, some of you probably already know, but telehealth reimbursement parity is always asking for something that's equal to what already exists, which is inherently exclusive because we're asking for payment parity for things like store and forward, remote patient monitoring. Those services don't exist without telehealth. So we're asking for something equal to something that doesn't exist, which is a net of zero. So it's really confusing. And also the laws are mostly tailored for parity in services, not in payment. As we'll see on the next couple of slides, there's only payment parity in 3 states right now. And the definitions of how you define everything in telehealth matters, and every federal agency, there are 7 federal agencies that have different definitions of what is telehealth and telemedicine. Each state has their own Medicaid definition, payers can have their own definition, and then the states can create their own definitions. So it gets super confusing really quickly. If you're trying to deploy one program in one state, you've got to check with all of these things and see, can I even do this? Is this even legal? Let alone, am I going to be paid for it on top of that? And then the language matters, and there are a lot of restrictions. So I always say, like, as a regulator, the more words there were, the more restrictions there are. So lists and laws or regulations are frequently outdated. I always would get calls from people saying, you know, I see this list in the regulation, but I don't know if this one box fringe case that's way in the corner applies. Can I even do it? I don't know. Okay, so it's better to try to be, find the balance. I always give the image of someone walking on a tightrope, like with protecting privacy and security and patient access and rights with innovation at the same time in the policy language. It's a really fine balance because you have to go back and open up the regulation to modify that list, and that changes, that opens it up for everything. You can't open it up just for one section. And then other variances for telemedicine specifically are listed there on the slide for you. People and states and the feds everywhere across the board, they have differences in opinions and what can and cannot be done with each of these things up there. Some states have laws about, for example, state employee health plans and what can and cannot be covered for telemedicine services, and some don't. So it just starts to get really, really messy really quickly because there isn't a federal national standard in place that we can follow. Words also like may or shall and must. So, and then negotiate with each payer. So as a telehealth program manager, I don't even know where our contracts are with our payers and how to start to uncover, oh, if we do this service with this payer, we get reimbursed this much. How can I possibly start to do a return on investment analysis and cost savings analysis if our negotiated rate with each payer is different? And then do our contract negotiation staff even know about telehealth and how to negotiate the best rates? It's all up in the air and it changes all the time. So it's just currently messy, but we're still doing it. Everyone's still trying to make some progress around all of these things, but we need to do some cleanup and move forward. So 31 states and the District of Columbia have some mandate for private health insurance plans. That ranges the spectrum of they could do it if they wanted to they must do it, and then they must do it for same as an equal payment to in person. 48 states and DC have some reimbursement for telehealth medical programs, and 49 states have some telemental health coverage. Again, that ranges the gamut from useful to not useful. Next slide. This is the state private payer payment parity. As you can see, there are 3 states here that have payment parity laws in place. And I put the very last slide in your packet in the appendix is the actual language from those 3 state laws for us to reference through this conversation. Already this map is a little outdated because Iowa just passed parity, not payment parity, but they should be blue. So you can see things are quickly changing, and those are the only 3 states that have actual payment parity. All right, so Senator Becker, you probably could do this better than I. But here's an overview of the bill that was recently passed. It goes into effect on June 7th. And there's some background as to why we're doing this, because there is variance in how people reimburse and pay for things and looking at it. So what should we do for the state of Washington to help move the needle forward, and what are the goals? And it was really helpful to have some of that background information that we talked about earlier today and how those 5 conditions were selected. So what is the work that this collaborative has to do? Review payment parity and develop recommendations for reimbursement at the same rate for store and forward as in person. The conditions are listed there. They included consideration of facility fees, because as you know, those would currently go away with these services, or they could go away, they don't have to go away. And then define the parameters for a pilot program, looking at claims analysis and also training programs for providers for delivering the service, but also billing. Going back to the conversation we had earlier about claims analysis, that's great, but things that aren't included on the claims, like return to work and miles saved, things that aren't being currently captured in a systematic way that we wouldn't be able to pull, that goes to the comment of we'd need a full-time data analyst to even start this. I don't even know how I would collect it, honestly. So what does the national landscape look like on this? Just a primer. There's starting to be a shift in the industry about changing the dialogue from removing the word parity, because like I said, you can't have parity for something that doesn't already exist. So sure, we have parity, but it's not really what we wanted. That's not what we asked for, and that's just it's nobody's fault. It's just the way that the industry has moved, and we're seeing that shift, and now we're realizing, hey, parity isn't really what we meant. That happens all the time. In the state of Maryland, we were like the 9th state to start to have a bill passed to require payment for telehealth services, and the payers negotiated in there something about clinically appropriate, which we were like, okay, fine, we'll give them a win. But 2 years later, we see that was really bad, and we had to go back and change it, because what that meant is now payers could do prior auth just because it was done by telemedicine and decide if it was a clinically appropriate service. So it had an unintended consequence when you add in all those extra words and things. So that's an example of that.
So use a KISS methodology.
Yes, exactly. It's a good way to say it. There are some exceptions, of course, like radiology remote reads that is technically telemedicine, but a lot of times people don't consider it that way. So how did they slip under the radar for so long? Can we follow any lessons learned from them? And then what should this payment for this service look like? We don't know, because it hasn't been really hugely paid for. So especially in an environment where we have some fee for service, like Dr. Scott was mentioning earlier, and then some risk-based models of payment. So it's a little different in all cases. What technology requirements should we have in place for safeguarding things? You know, HIPAA is the floor, not the ceiling. So how should we ensure that our patients' visits and data being transmitted virtually are protected the same way they would be in person? And then what upfront investments are required? Are those equal to or less than in-person visits? You know, what does it look like when you don't have to pay the security guard up front and the registration and, you know, building and maintenance and all of that, but instead you're paying for things like infrastructure and network? And whose responsibility is it to pay for those things? Next. So 23 states have laws on the books for private payer, store, and forward, and it's across the spectrum. Sometimes it's just included in the definition of telehealth. So therefore, store and forward services must be reimbursed. But sometimes, like Minnesota, it requires full payment parity. So it says it shall, which means may, be paid for at the allowable rate. And the definition of telemedicine includes store and forward. So it's not required, but it's there and it's possible. So that's something we can think about as we look at that state. 17 states have laws on the books for store and forward with their Medicaid program, and same thing again. Some states are very specific to which conditions can be treated by store and forward telemedicine. They'll only reimburse for those, like California, but other states like Mississippi has things like the employee benefits plan must pay for store and forward services. So again, all across the spectrum. Included in the appendix of this slide deck are the states and excerpts from their laws related to this. It's also, you get conflicting information from the industry advocacy organizations itself. Like the American Telemedicine Association says 17 states have laws on the books for Medicaid, but the Center for Connected Health Policy, which is a telehealth advocacy organization, says 13 states. So it's kind of like you got to do your own research and literally look at the laws and see, why are you counting this versus not that? What does it look like? So now I'll give you a little bit about the Maryland Telemedicine Task Force, because they're kind of like your brother on the other side of the country. So in 2010, the task force was legislatively mandated to look at laws for payment parity. It ended up morphing into just parity in general for services. It wasn't actually payment parity. We got credentialing by proxy passed. That was a recommendation that came out of the telemedicine task force. And then in 2012, the task force was reconvened and expanded into 3 advisory groups. There was a technical group, a finance group, and a clinical group. So I was the person who ran all 3 of those, and then there was a chair for each of them that I worked very closely with. And we had developed recommendations that came out of that. At the same time, in parallel, the bill was being routed for the reimbursement and the definition of telehealth, which in the law was narrowed down to just audio video, but the telemedicine task force took that up, right away and wanted to add other things like store and forward and teleproctoring and teaching and all of those things. That never got passed, but it's been reintroduced every single year, including this past year. Still not passed. So as you can see, once something's there, it's harder to move.
All good things take time, right?
Yep. We also added things like we worked with the Federation of State Medical Boards to develop the framework for the Interstate Medical Licensure Compact, which, looking at how that's been actually implemented now to what the framework was decided on then, is night and day different. So we're even seeing things, it's frankly been disappointing to the industry about how that program has been implemented, and it's kind of like they took a baby step forward, but it's not really going to help a lot unless you are in some of these narrow use cases of wanting to practice in a lot of different states and you need an expedited licensure process for physicians only. In 2016, our recommendations report was submitted. We outlined 10 clinical use cases, so for pilot programs very similar to this, which is 5 clinical use cases, and then those have subsequently gotten some state funding through a grant that have been implemented. So I left at the end of 2016, but those grants got kicked off and they've done 5 rounds of those awards and are studying them and reporting back to the legislature. So what data did we use? Since the parity law was passed effective October 2012, and then this report was submitted in 2014, there was only that small amount of time for data. But what we saw, and I asked my old colleagues this morning, what is the claims data currently looking like? And they're saying people aren't really billing correctly for it. So the claims data isn't showing actual utilization. I don't know if any more than that at this point, but during the 9 months that followed the effective date, only 50 practitioners submitted 78 claims. So we could get some high-level claims data like that if people are submitting the claims correctly. Again, you're not going to get the value-based payments utilization rates for things like that, or if people are doing it and not adding the appropriate modifiers, which they're not supposed to do, but probably happens. That would occur too. And then in 2013, after the law was passed, so that entire calendar year, they only had 132 telemedicine claims. We also did a hospital survey where we surveyed all 46 acute care hospitals in the state and asked them about their plans for telehealth and what were they doing. 88% of them were doing some form of telehealth, but that could have included like teleradiology and things like that. And the primary reason was to improve quality and reduce readmissions. Maryland has an all-payer rate setting system, so all hospitals are paid the same rates, and they have a very strict readmissions policy, so that was a driving force early on with them. Another win, I guess, for the telemedicine stakeholders in the state of Maryland, the Department of Health Medicaid office was very resistant to adopting any laws or regulations about paying for telemedicine services. They wanted to ride the heels of the private payers and see how it went. There was a fiscal note put in with a bill that suggested that there would be a $6.3 million increase in Medicaid expenditures in 14, and then $8.5 million increase in 15. But despite that, they started looking at the savings and looked at avoided transportation costs and emergency room admissions, and then the downstream impacts of that, and decided, hey, I guess we'll do this anyways. So there was that upfront cost that they were looking at, but then they also added in the cost savings part of it, and then we got parity, and we helped write the regulations for what that program should look like, what technology should be in place. That was one unique thing that Maryland did back then, was write into the regulations technology standards, which couldn't be, you can't. What we decided to go with broad language that said it had to be clinically appropriate, so that you see very widespread these days. But for some services, you only need, for example, a webcam and an internet connection. But other services, you might need things like peripheral devices to actually do a good job at the visit. So if you can provide this service clinically and you think it's clinically relevant, then you could do it by telemedicine. We didn't want to start listing which services could or could not be done. So some key policy takeaways. Words matter. The inclusion or exclusion of certain things could have unintended consequences. And then you have to go back. You can never predict the future, right? And we don't know how things will change, but we could give it our best shot out the gate. Very few, only 3 telehealth private payer laws mandate parity, payment parity. And a lot of times there are exclusions written in to the types of services, providers, locations, the patient site, as to what will be paid for these services. So it's much more complicated than an in-person visit, and it requires all these different processes for every single healthcare system to think about and consider as they're developing their programs that are different than in-person services. So now you're asking providers to learn these 2 different separate things, when really telehealth should just be another modality of service. I tell people in 5 or 10 years, I don't ever want to hear the word telehealth again, because it should just be another way that you can access care.
Before you leave that slide,
yeah.
Point 3 or bullet, what is RPM?
Remote patient monitoring, sorry. Yep. So store and forward and remote patient monitoring, those are those 2 services that aren't really equal to anything in person today.
Can you give some examples of RPM?
Sure. So if a patient has a wearable device at home and they're checking their heart rate, for some reason, they could be sent over the internet to their provider, and the providers can watch their heart rate for any chronic conditions.
Or blood sugar for diabetes.
Sleep apnea.
Yep.
May I ask you a question, sir? On page 7 of your slides in 2011, credentialing by proxy pass. Can you explain that a little bit more?
Sure. So just the baseline requirement today, every hospital required their own credentialing process and privileging process for their physicians. So when you start to want to do telehealth and go from one health system like the University of Maryland and then offer services to Johns Hopkins, that physician would have to get credentialed and privileged at the other place. So the law allowed for physicians or hospitals to accept the credentials of another state's hospital so that they didn't have to be credentialed and privileged at all 46 hospitals, which would be a huge administrative barrier to telehealth.
I remember doing temporary privileges for, yeah.
We require that at UW. If you want to be a partner with us, you have to accept proxy credentials.
Time down.
Oh, yeah, yeah.
That was an easy one to pass.
That seems to me like a no-brainer to work on. And is it based on NPIs then, or is it?
Mm-hmm.
Okay.
Exactly. So an experience at Children's right now, we do some work with in Montana. We fly our docs out to Montana. Montana doesn't have credentialing by proxy. So we've got to build that in, that timeline, and do our upfront. They've got to get fully licensed in the state of Montana and also credentialed and privileged. So like, we want to do this virtual visit next week. Like, you're not doing it.
The nice thing is that CMS and Joint Commission endorse that. But even in our own system, in certain states, we have huge resistance to that. So it's not ubiquitous. Right. But sorry.
Nope, that's good.
Sarah, any other questions or comments before we maybe open it up for questions here? If folks are on the phone, want to start typing in questions on the chat, and we'll be taking those as well.
I had a couple more slides about thoughts for how to measure access, quality, and cost that have been researched and kind of used as an industry standard that are listed there. We don't need to go through them. Looking at different process measures, outcome measures, access measures, and then here, some thoughts for the collaborative on slide 21. So we'll need multiple sources to paint the whole picture, right? The All Payer Claims database is a great start. A lot of states don't have that, so it's nice to at least be able to have that data. Looking at the denial rates, like we've already talked about, looking at the landscape. So where is telehealth happening? What services are they doing? And what is the frequency? That'll start to give us a picture of who's doing it and how are they doing it and how is it working? And then how can we take that and use it for lessons learned as baseline requirements for other programs? And also policy analysis. So looking at the other state policy language, which we've started to do, and look at the gaps, and then what do we want to do for Washington? That's all. Thank you.
Great. Thanks, Sarah.
Sure. I had one comment on that. I'm also curious about doing a gap analysis in terms of who's not utilizing that could be utilizing and why they're not utilizing and what the barriers are there.
Where would you start with that, Joelle? Like, who would you reach out to?
Well, I think you need to look at health systems and even smaller systems and understand what their utilization rate is, and understanding what the rate of utilization should be based on, you could probably go in reverse order and look at claims on stroke, for example, and say, okay, how many of these stroke cases could we have utilized, or should we have utilized telehealth?
Is this something like WISHA could help us out with? Like send a survey to their...
So I keep thinking if Washington Health Alliance might have access to that kind of data too.
I keep thinking of, I mean, how much trouble we were having getting the information about the preventive services. Were they, you know, when you're looking at maybe a 1,200, I'll just throw out a number, but a 1,200 patient panel, and only 450 have had their preventive services or their, you know, exam. That's the information we can't get to see if there's a gap easily. We wait for a report that comes at the end of the year, and if we could query that and find out, then during the year, you know, that's how we can reach out to some of these folks for telemedicine and say these services are available, you know, you can start this way. But that's Medicaid only.
Right.
Yeah.
And if the dashboards that are reporting that data are accurate
and
on the user end.
Yeah.
Yeah, well, we do a combination of, you know, take the HEDIS measures, you know, and we look at gap closures, and we have a running, you know, every month we pull gaps on our you know, value-based care contracts with our providers and say, these are the list of people who haven't had their A1Cs for the past X period of time, or, they don't have recent blood pressures or whatever. And so it's a lot of data pulls, it's a lot of customized reports, but it's really what you have to do to be able to stay on top of it and get that in front of the provider so that you have something to talk about. Say, we can close this more easily if we just did.
I think it's also going to be really helpful if we could garner healthcare economists and actuaries to actually look at the cost savings. And I know we've talked about cost savings, but looking at zip codes and incomes in those zip codes and what it would have taken for people who did receive those telehealth services to travel, really kind of looking at these communities, but also if delayed care had occurred, especially in those acute care settings, what could have been the predicted outcomes, if that makes sense.
And the behaviors are a lot different in the commercial, market, commercial consumers versus the Medicaid population. We're seeing time of day utilization, we're seeing frequency, we're seeing, what people are calling in for. It's very different, at least if you're looking just at the niche of virtual care. Partly I think that's driven by payment. So if I'm paying $35 and I have a cold, I want my cold treated, where our Medicaid members aren't paying anything. So they're sort of agnostic to cost. They go in and, oh, well, yeah, I've got the cold, but I also have these other 10 things. And so the visits tend to be a little bit longer. And even though they have maybe a little more referrals because they're more complex, it's an interesting and different demographic. So I think while it's easier for Medicaid, I totally agree with you. It would be really helpful to have a really strong analyst actuary really work on the commercial side, because that's harder to get to.
I have a question. Don't you really think, though, that with everything out there, that you should have a pretty good idea who your frequent flyers are?
We do. Oh, yeah. We follow them. We track them. We try to get in front of them. Yes, absolutely.
So that you could use this for some predictability.
Yep.
We do that in other areas.
We do that.
Most likely we need to concentrate on this group, or this subset of the, of your panel that you're referring to.
The thing that keeps Medicaid, because it is a zero cost to them for everything, but when you look at who's not getting services right now, it's our middle income folks that have these huge deductibles. And how do we reach out to them and make this worthwhile? I'm talking to people in Yelm and Eatonville and Elby and, et cetera, that are excited to learn that this is coming forward, but they don't know enough about it yet to figure out how to use it. So, but it's that middle income person that...
Francis, can you say a little bit more about how you're trying to market this and advertise some of your
Yeah, sure.
That was one of the questions that came in. Yeah.
Well, again, I'm talking really exclusively about a Medicaid population, which is, again, different. But, we know our members are mobile. Yep. They couch surf. Many are in shelters. They live in very different environments than I think you think about it as a home. And so as a result, they don't have computers, but they have mobile devices. Generally a cell phone, might be a smartphone, but usually they even have smartphones. Probably about 80% of our membership has a smartphone. So that's how we try to reach them. And they also, many of them out of 600,000 Medicaid members, we have the email addresses on about half. So it's wonderful now that in the demographics that state collects, email addresses are being collected. So that's super helpful because they change the least. So we do a series of campaigns. One is we use search engine optimization to try to get our information up front so that when our members are looking for virtual care services, they can connect back to Molina. That's one way. And then the other thing, too, is by email campaigns are hugely effective in the population dramatically. And it's very seasonal. So if flu season's coming, we put a big push out, we really see a big jump in our utilization. Yeah. Not nearly as much as we hope to. We have a long way to go. But at least it's effective because, our Medicaid membership, like anybody, we hear about it through social media, and that's how we communicate best with our members, too. No. Snail mail doesn't work very well. No. What does work, though, actually, to the point about really working with these, high utilizing members is getting our community connectors, our case managers on the ground. And we tested that out in one of the areas in Southwest Washington where we did a combination of just on the ground grassroots campaign along with the search engine optimization piece. We had, it looks like if you map it out on a heat map, it looks like a metropolitan area. There's so much utilization there, but it's really because of this grassroots, getting out in the communities and really telling people about the service.
Yeah, just to expand on that, one of the things we've done is when people are in the hospital and being discharged, that's when we say, hey, we're going to do your follow-up, or your case manager is going to contact you, but this is how you use it, and they give them an information sheet. So you kind of strike when the iron's hot.
Absolutely.
Yeah.
Resistance? Do you have any resistance when you're doing more and more on the phone, or are people welcoming that?
Well, the satisfaction rate is really high. We have a super high satisfaction. I think it's because, you can imagine, I always think of a young mom going, dragging 4 kids into the emergency room, taking them on the bus. How are they going to get there, waiting for 4 hours, versus picking up the phone? Oh my gosh, the satisfaction is so high.
Yeah.
And I think that they get a lot of time, too, through the service. So they're not hurried, they're not rushed, they don't feel like they're a second-class citizen. They feel, that their concerns have been honored and that a follow-up plan's in place. And they can also make meaning the telehealth providers that we're working with, can also make a direct referral to case management. And so if they're picking up that there's an issue, they can make a direct referral, and then we always loop them back to their PCP. So they've got that. They're always, focused. And if they have a medical home or just getting connected to a primary care doc is always one of the outcomes, the mandatory outcomes of the visit. They don't have it already.
So something that you said really intrigued me, though, because giving the information, you did, Dr. Scott, giving the information out when they're being discharged from the University of Washington. We have a lot of folks that their first contact is with the EMT and the fire department.
Yes.
And that would be a perfect time to give that information out so that they, rather than calling for that, they could. It's a perfect time.
We do some of that. We have some pilots going on that connects them to their case manager, because oftentimes the high utilizers do have case managers. So we call them first instead of sending people into the emergency room, and they do it through that. But that's a direct connection would be really good. It's a great idea from EMT.
Yeah, Professor Schmidt, can I just answer your question about concerns of patients? I think, speaking from our virtual clinic experience, probably fall into 2 categories. One is people complaining that their issue wasn't definitively resolved through telemedicine. For whatever reason, they needed to be examined or get a test. So then they feel like they're being billed twice for the same service. So that's a real concern. However, we say that we often have spent 20 minutes with them and helped to triage them. And a lot of those people actually go to urgent care rather than the ER, which is quite a bit cheaper. So I don't think they realize that that triage, there's value in that triage. The second complaint is really about their expectations. So they want their antibiotics, or they want their pain medicine or whatever. They have an alternative agenda. It's usually about getting some kind of medication, and we just it's the same issue we get in person. So, but we have about 90% satisfaction.
Go ahead.
I don't think that people, especially in the Medicaid population, realize that if you're going in to see the doctor and there was something else identified, that has to be a second visit. Yeah. It's not like you can go down the hall and take care of it right away.
Yeah.
So people don't know.
Yeah, we try to do a lot of that advertising up front on the website, and quite honestly, they're just not reading it.
Yeah.
Sorry.
And I was just thinking, one of the barriers to implementing and disseminating telehealth is provider hesitancy. And I wonder if that's something else that we need to look at. But given your experience, Dr. Guff, at Carina and currently, what you're seeing and approaches to socializing providers to that as well, so that they can get over that.
Well, you're absolutely, you're right. It's always, you never want to be in competition. That's not, at all the reason that we have the service available. It's really meant, and it's right out there, right up front. It's when your own doctor is not available for whatever reason, then here's a fallback. Absolutely call your doc when it's appropriate. Call the ear when it's appropriate. But, if don't think you're having a heart attack and you can't reach your primary care doc, now's the time to pick up the phone and pick it up before you go in reflexively, to the emergency room. So that's sort of the messaging. But I can tell you, and having stood in front of a lot of panels of docs having to talk about this program, which sometimes is very uncomfortable, we always end, though, on the note that, the fact that they get there, I ask them, are you getting your follow-up the next day? Yes, we get a note the next day. And yes, oftentimes it's 2 a.m. And you know what? I am really happy that this service exists because they know that we are not only a resource for them when they can't be there, but we connect the patient back to, to them. We want to keep them in the medical home. So, and most are really happy. And the conversations I've had lately with some of the big health systems, it's like, how can we market it? How can we co-market it? Like, wow, great. And I'd welcome, again, any feedback that you're getting or seeing, but for the Medicaid population, I think it's particularly since there's a high no-show rate, and it's oftentimes hard to get, patients into be seen at all. And providers care about that continuity, but they just might not be able to do it themselves all the time. So this is a way to support that.
To your question, Joelle, fact of the matter is providing care virtually isn't for all providers, right? There are some providers who are not comfortable with the technology. There are some providers who I've heard are newer out of school, and they said, I don't have enough experience yet to be able to do this effectively. I want to get some more hands-on before I transition to it. In my previous role at the University of Wisconsin, we required all 16 urgent care APPs to at least go through the training and try to do it. Within 3 weeks, we already were pulling some off because they just couldn't do it. They didn't want to do it. It wasn't a thing for them. So we found really understanding and meeting the providers of where they're at and helping them make the transition. Some of them who started out hearing about it, who had never even done an instant chat before on their computers, ended up loving it and doing it just fine. So it's really you can't force everyone to do it kind of thing, and your service won't be good if your provider's not happy.
I think Brody had done some research of what's been going on with some of the Blue programs in Hawaii, Minnesota, and Delaware. So Brody, I know that was pretty preliminary, but would you mind just sharing kind of what you learned from your colleagues in those states?
Yeah, so I was hoping we would learn more, but I think the main takeaway is that either there hasn't been enough utilization for them to determine whether there was an impact to the program, or maybe they're not even looking at it. We couldn't really drill into the details as to why, even though some of these programs have been in place for so long, that they don't really have any results to share. So most of the feedback that we got was just related to how they work together to at least implement the program. So again, the results aren't there, unfortunately. So I had some of my colleagues contact their contacts at the other Blue plans, and so we got feedback from Delaware, Hawaii, and Minnesota. What we learned from Delaware was that essentially the theory going in was that this would be most beneficial for the rural parts of the state. But interestingly enough, I'm not sure if this is true or not, but what they shared with us is that according to Medicare, Delaware actually doesn't have any rural areas that fall in that definition. So it's kind of a weird hypothesis that went through that really didn't really apply in this case. But what they put in the requirements was that the legislation did prohibit providers from seeking reimbursement for telehealth when that patient ended up going in for the same issue. So I'm not really sure how they administered that, but there was an aspect of the legislation that you had to bill for one or the other. You couldn't really bill for both. And it seems like the telehealth portion of it was not reimbursable if the patient actually ended up going to the office. They also stated that they didn't give us a lot of details, but there is some support system that is available if issues arise. So I'm not sure if that's a resource that was provided to the providers or if it was more than that, but there was some support system for issues On the Hawaii front, this one by far seemed to be the most collaborative of the states. I think the other states were viewed as less collaborative as far as everyone working together on it. So it's been around for a while. It's primarily focused, I think, on the telestroke aspect. They did convene a group to work on it together, so I think it's very similar to what we're discussing right now. It seems like of the 3 states, they had this collaborative group working together, and so far they just said there are a few problems associated with it, and that those from the government side have been really supportive, and they seem to think it's a good partnership. However, as I mentioned at the very beginning, there are no results that are being reported at this time, even though it's been around for a while. On the Minnesota front, what we learned was that the initiator of this was the Hospital Association. They had very similar focus of it was whether this would increase cost or decrease cost. So as I mentioned, no reports of the effectiveness of the program have been shared, even though it went into effect in January of 2017. And they pointed out in some conversations we've had in other meetings, just there was some highlight of whether broadband issues across the state, especially in the rural areas, whether that would be an issue here or not. Again, no real reports on outcomes at this point. So yeah, in short, seems like they've all launched, yet there are no real reports of what its impact has been. So unfortunately, we weren't able to get that information.
Oh, thanks, Brody. Was there any best practices in terms of how they structure this? It sounds like Hawaii maybe is a leader there, that like anything they would be willing to share with us about how to actually study it, because I think that's where we are now.
Yeah, they didn't share anything beyond the fact that there was just a collaborative group that was basically designated to discuss it, very similar to what we're doing right here. If we have specific questions about how it was structured, we can definitely follow up with them on it. But in the conversation, they didn't really share any specifics.
Okay. Yeah, even if you could just connect me with maybe whoever's the convener of those things, and I can maybe collect questions and we can reach out to them, that'd be great. Because it'd be nice to not reinvent the wheel.
Yeah.
Good. Thank you so much, Brody. Cheryl Huchala, did you have an opportunity to reach out to your colleagues in those 3 states? I know it was a little last minute.
I wasn't able to. I apologize for that.
Okay. Great.
It's weird. The Pacific Islands has a resource center. I wonder if they could connect us with somebody to try and identify the data source.
Do you know the folks in the Pacific Island TRC? Yeah. Would you mind reaching out to them, Dan?
I don't know. Pursue the other 2, but we could do that route as well.
Yeah, that's a good idea for the TRC. Okay.
I can call NCSL, National Committee State Legislators.
That'd be great.
Because they have a healthcare team that maybe can help us.
That'd be awesome. Well, good. I wanted to pick up one of the things that Sarah said about how maybe that there weren't that many claims because they weren't being billed properly. And Danny had some comments and some things to share about coding. And then after that, I want to start diving into, again, the 6399 language and start mapping out some action plans and responsibilities for that. Danny, do you want me to pull up some slides? Which one is it? Okay. I'm gonna have to.
So this is assuming that we're following along the lines of the 5 clinical services that we started talking about. One of the things that we wanted to make sure we're identifying is the CPT codes that would be used in all of these services and the provider types that are also used in these services. So we reached out to all the provider types in our system and tried to collect all the appropriate CPT codes. So I would encourage you all to check with your folks too and see if there's any glaringly missing. I think we only added a couple. One of them was pre-diabetes education. that's done by diabetes educators. I think that's a good proactive resource there. And then for many of us who do telepsychiatry, we're often using more in the lines of physician extenders like social workers, LCSWs, when we're doing telepsychiatry, particularly in the ambulatory environment. So we want to make sure not miss that. And then we also included in the mental health conditions, just the same way we do for stroke, follow-up visits and consultations in the emergency room and on inpatient units in the hospital. So those were really the only additions there. So I think it's a pretty comprehensive list of CPT codes for these disciplines.
Great.
Can I ask a question?
Sure.
On Medicaid, when you're billing for, you're billing for your caseworkers, I'm assuming, or they,
well, we sort of do. I mean, they're part of the they're
team.
part of the, well, we have, when I was referring to case management, there are Molina case managers. So those are just part of the budget, sort of the overall budget sort of built in. So we don't have a separate billing specifically.
Would that be equivalent to care coordinators? Same thing.
Some of them are care coordinators, some of them are case managers. You are licensed social workers. It's not a separate billing. Yeah, separate.
Because I'm looking at it, there's two different reasons to look at that, the CPT code, but then who is providing the service can, as we start to look at this and who is then doing that follow-up and have we actually saved money, then we can actually look at that long term and maybe that's a code we need to think about.
And we would probably use that in remote patient monitoring too. We've got
Yeah.
folks reviewing that data and responding to it. Somebody has to do that.
I know that in Mississippi they have a Medicaid reimburses for diabetes RPM, remote managing. I don't know that. So, let's see what those codes are. Can I ask, as a follow-up item, can I ask Francis and Sean, Brody, and Cheryl, and I'll ask Chris to just double check these CPT codes and make sure that we're not missing any in terms of things that would be relevant to those conditions. The mental health is pretty long and comprehensive. Cheryl, Chris Cable.
So can I ask you a question, Denny, on your chart? I'm looking at opioid dependence, and you've got your hit picks, but would you be then not looking at office calls in addition to that, like a 99213 with modifier? And
Yeah, because I mean, you would. Yeah, I mean, if you're doing like buprenorphine follow-up, you'd want to have that. Could have an office visit.
So what is it?
It's a 992.
213 to 215, or in
or
the nursing.
01 or 01
or 0. Yeah.
01 through 5.
99.
So just the same code you had up top for mental health. Your 99201 through 215.
Right.
But that's in the red in the second.
Seeing chronic pain and would be the same thing.
Oh, for both those.
Yeah, they're in red because Denny added them.
And diabetes, because you'd have office calls in there.
And that's going to be your meat and potatoes, is the 99201 through 215, right?
To new patient and your established patient billing charges.
Okay.
With modifiers.
This is Cheryl, and I've got a question. So then do we need to identify diagnosis codes? Because those office visits are very generic codes.
Yes, I think so.
Yes, you mean like ICD-10 codes, Cheryl?
Yes.
I agree.
Probably would. I mean, that's going to be very, very long. Yeah. We could probably start with the most common ones like, depression.
They're in groups in the they're grouped in the ICD-10 book.
You can start with some.
Somewhat.
Yeah.
Yeah, somewhat.
All right. Great. Anything else, Denny, that you wanted to highlight? Good. Okay. So maybe we can go back to the legislative directive here. Of basically, what do we need to do over the next 6 months So it says, review the concept of telemedicine payment parity. And I feel like we've actually done a pretty good job with Sarah's background today and what Brody has told us. As a follow-up, I will reach out to those states and try to learn a little bit more about their structure and how they're studying it. But I feel like we got a nice good start on that. The second here is to develop recommendations on reimbursing at the same rate. So it sounds like the first step is to know what the codes are. We've done that, and for what diagnoses. And I think the provider groups, we should help to collect those codes and what we potentially be submitting bills for. Do you agree, Denny?
So I'm just curious, given that you have more time now, would you think it differently? Well, okay, I retract that comment.
We're getting our house ready to sell. I haven't had any time, but that's okay.
Okay, I was just curious if you would think of it any differently at this point.
So here's what I think. I think we kind of have to think of it, you know, when we hit, I'd like to be able to pre-file a bill. And that means have it done and ready to go by, what is it, December?
First part of December.
And so that means, let's work it backwards. And what that means is having a bill that we've worked with the carriers, we've worked with the hospitals, and we've worked with everybody ahead of time. And, you know, so that when we go to the table, we don't have unintended language, which is going to happen anyway. And then I think strategize, do we want to have everything in one bill or do we want to break it up? Because if we break it up, we have a better chance of getting something that may not be the entire picture, because I think moving forward, this is going to be an incremental process anyway.
Well, the hospital, like the credentialing from different hospitals by proxy.
That's already going into my bills. I mean, that's crazy. If we can do it by NPIs and do a Washington State credentialing, I remember as the person that had to submit all that stuff, how onerous it was. But I had everything on my computer, and it really actually got to be pretty easy. But work it backwards. So this is our timeline. This is our goal. What is it going to take us to get here to this goal? And how can we have maybe a collaborative meeting and have hospitals and the insurance carriers here more so talking about specifics of it, so that we're not faced with people across the table looking at each other going, you know, because that's what happened this last year, is that, well, if we don't say anything and they're not going to give on that, we're okay, you know. So, but I also think there was an interesting point that Sarah made is, we're talking about payment parity, but what is parity for medical? And I thought that was really an interesting point. I think maybe we should look at that as well.
Or parity where it doesn't exist.
Or
through
parity
through the different definitions.
And maybe it's just RPM. That's the only one I can think of right now.
Remote monitoring of these folks.
What are you thinking for proxy that you would put in a bill?
Well, it just made perfect sense when Sarah was talking about that.
If you have
the ease of our physicians.
Credentials at a hospital and another hospital, you're wanting to use the services of that doctor. It would seem to me that should.
The biggest resistance we're running into is medical boards within the hospitals and standards. In other words, our standards here might be different than Alaska, and that's exactly what we ran into.
I'm thinking of just Washington State, because we've got the compact. I'm thinking out loud. I'm throwing spitballs at the wall right now, okay? But if we
start
look at it
in our state, then you can start. When we get a little experience, then we can go outside of the state to do that.
Okay.
This is a small step process.
So are you thinking it's now legal, so you should do it, or we encourage you to do it, or?
Yeah, just to Denny's point, it's, the Joint Commission came out with kind of some wishy-washy language on the fact that they accept it and they endorse it if it's possible. But I kind of wanted to make a stronger statement. We bump up against this a lot, and that it's not necessarily within the legal parameters that we have challenges. It's convincing a small hospital who's got limited resources that they should really take faith in the fact that our credentialing process is thorough and we vet appropriately. And so it's almost like, can the state even provide a little guidance on this? And so I don't know where the parameters kind of.
So do you have a best practice as far as credentialing? Do you have a
Yeah, usually when we run into this resistance, let's say a critical access hospital, we'll give them the CMS language and they put it in their bylaws. And generally, we haven't had much resistance to that, except for certain other states.
So there's ways
it
to
exists.
do this, but we should start talking about this.
Yeah.
Is this something where MQAC gets involved, or is it a WISHA kind of thing?
I'm trying to remember if it's in their language.
No, it's not MQAC. Who do you go through?
This is the hospital.
Because I'm actually think about it, when a doctor or a provider comes in, and I'm talking medical doctor, and I think psychiatry goes through the same Department of Licensing, right, for your license.
Yeah.
You still have to go through, it's almost virtually the same credentialing packet that you send to them as, so maybe we could streamline it with some guidance.
Yeah, like state recommendations on the very basics that are.
And it could be done at the Department of Licensing. I mean, I'm just throwing out ideas that are coming. I look for.
Usually we do the full credentialing at our hub hospitals. And if they're in good standing, then they're in good standing everywhere else. I'm trying to think. They've been fully vetted at our own medical staff.
Can you follow up just real quick? Do you find that how much of a variance is there between the different hospitals and credentialing?
There's not a lot.
Well, I was on credential and privileging committee for over 10 years at Swedish, and through the alliance with Providence, and the variation was a huge challenge. And then myself, as a telehealth provider, needed to be credentialed out in Port Angeles and Sequim, Port Townsend, in those areas, and there was a lot of hesitancy. And the bottom line is we don't have we don't have practice standards when it comes to credentialing.
Right.
To say this is the floor, this is the ceiling, you've got to come in here, so that we can all feel confident that you've onboarded people safely and responsibly, and that your ongoing privileging and credentialing is sound in terms of monitoring people. If we wanted to, we could bring Clark Kohler in, who's presided over that committee for 2 decades, and he's so knowledgeable. But it might be helpful to get someone in here that has dealt with all of these inner workings.
And we've had Joint Commission in at a number of our hospitals lately, and they're asking more serious questions. They want to know who the medical director of that program is and how are you assuring compliance and communication about issues.
And competence.
So you come into
providers.
You come into JACO.
So we have to document even more thoroughly than we did before about communication out to all of those partner hospitals.
So we just went through about a 2-year process to have proxy credentialing between Seattle Children's and Harborview. And we have language that we'd be happy to share. It's about making sure that everyone's trained to the same standard. That's one thing. Second thing is any kind of disciplinary action taken at, say, Seattle Children's, we need to know about that within 48 hours, I think is what we decided on. So it's actually not all that complicated, but if you want to, I can give you some language that would be basically what we use in our agreement.
I think this would be one of the neatest things going, truthfully. I mean, that's why I'm not questioning you. I'm going, like you.
Well, it's gotten us down to about 30 days to turn physicians around, which is pretty good.
Okay, that's a good action item. We can get that out. One thing that I have asked Thea to do next time, Thea Mounts from the Department of Health, is for her to explain what's in the all payers database, so we really know what's in our data source.
So I can tell you a little bit about that since I'm the sponsor of the bill.
Okay, great.
That database is designed to capture everything on a HCFA 1500 or your, I forgot the term for the hospital billing for
UB?
the what?
The UB?
UV, yeah.
Yeah.
And so it's to pick up every single bit of that information.
Okay.
But that's it in a nutshell.
Okay.
But that would be great if she came in.
What other things do we need to do for our next meeting here? A good start? Okay.
Do you think that do you agree that we should start from our goal of our timeline
Totally.
and work backwards?
Yeah.
And
sounds like the proxy is definitely achievable.
That's completely separate, but yeah, I think
Do you think that we're going to need more discussion around utilization? For example, the use of stroke. How do you determine whether or not you're adding utilization by using telestroke? A patient either comes in via ambulance or they use telestroke in a rural community. It's kind of hard to figure out what baseline is.
Here's another consideration. A lot of times, for example, telestroke programs, they have clinical services contracts in place, so that's not captured necessarily on a claim. It doesn't. If the arrangement is between one facility and another for payment of those services, we wouldn't get that from the APCD data.
No, you wouldn't.
Right.
Those are proprietary, though.
Yes. So how would we?
Well, that's also kind of then like Teledoc. That's the same situation.
Sure. Cash pay up front.
The telestroke, I know every one of my critical access hospitals utilize that, and they like it. It's working well. That protocol. So it would seem like that it's happening. It's just a question. You're trying to, how do we get data that we can use?
Well, if you're a stroke patient presenting in a rural critical access hospital, you're going to either have a neurologist at the bedside, which most don't, right? Or you're going to pull them in. So there's an automatic increase of stroke utilization. How did you guys look at it?
We used the same vendor platform. So we used the information that was collected through the hardware and software that we were using to calculate.
So just connections.
Yep.
Okay.
And length of time of those connections. Sorry.
Yeah. And you could look at time to thrombolytics, right? Or time to standard practice, standard treatment.
Having worked with Denny, though, it's interesting. A lot of the rural facilities you guys are talking about still don't have robust data. And so when you talk about door to needle, I think, just counting on my Providence days, it was kind of a challenge even to get that level of data sometimes, just because folks don't have it and they weren't collecting it. And so, thank goodness that the American Heart Association has come out with some telestroke guidelines that we're all trying to push our partners to achieve. But when you also think about the sharing of data beyond the platform that they're using, you're talking about getting data from two different entities, and that also has inherent challenges as well, which I think you're very familiar with.
Chart reviews.
Yeah, exactly.
But you could do
a monumental task.
You could do a sample.
Yep. Yes, you can. So yeah. I mean, even making recommendations on data is a huge step forward.
And you have to realize, though, what no one is going to be able to accomplish is we've gone from square one to the end product and have all the answers. We're looking for where could we make those improvements to have the quality and the outcomes. Either the timeline, the treatments timeline shortened or made better or whatever.
I guess the point is meaningful metrics to a payer, right? And how do we compare that against without the service?
My hospitals would tell you they've cut their transfers by almost over 30%. The time to seeing that neurologist or the proper is down in that 40-minute range, or under 40 minutes, because those were two of the areas that my hospitals kept track of.
Okay. Plus, they don't have to pay for a neurologist.
Yeah.
No.
So, well, you're paying for the service. I mean,
it's quite a bit cheaper.
But yeah,
With having a neurologist on staff full
Yes.
time, maybe we
well,
don't
that's
have.
not going to happen in a lot of my smaller hospitals.
I mean, if you
Yeah, so random regional sample maybe.
Yeah.
There's got to be a lot published on telestroke and cost savings. Yeah. So, but you and I do some data searching on that. We can report back. Anything else we need to do for next time? We'll wrap up.
I'm kind of curious what the payment models are in these 3 states. I mean, just a practical look.
Is
maybe for our 5 sample areas.
Senator Becker, is the topic of provider education still on the table? It is.
To me, it is.
Okay.
Because I met with Dr. Anna Retz. I always say your last name. Yeah. And I had her take a look at the Department of Health's descriptions, their scope for each of the groups, and she thinks that there's some, lacking some areas of training that needs to happen. But my thought on the education was to have them educated through the ECHO program, which we did not get that money, but we tried awfully hard. But educated through the ECHO program to a standard level, and then have them re-credentialed, but then have peer-to-peer support for some of these workers out there, especially in mental health. And then just try to do a continuing education like CMEs, like the docs do, so that they have a continuing training, continuous training, and they have peer-to-peer support, and we have a standardized training.
Okay.
And I think that, what concerns me, Danny, is when I hear people talk in the legislative body, oh, we'll just create these caseworkers, and it's a recovering drug addict or a recovering alcoholic, and then you throw them in with an alcoholic, and you don't know what might trigger a reoccurrence with that provider. And so there needs to be some care for that provider as well.
Okay.
And knowing that training is going to give them the ability to identify when they might have some problems recurring as well.
I guess
so
it's
is
that telehealth proficiency? That's what I was referring
to.
The
telehealth. Well,
sorry.
Okay. The proficiency, I think it's just so that my concern is that we give the providers enough education so that they don't become fraudulent in the group.
Sure.
That's all I want.
Is that still in the bill?
I can't remember. It's been a while since I looked at the bill, but it's anything that we want to do in here.
Okay.
But the other training is real important.
Sure.
There are some graduate level courses at the UW on telemedicine. Miriam took one of them as a graduate of one of those classes. So I just know that there are some of those out there in the curriculum. So we've got about 5 more minutes. So in terms of just some logistics, Priscilla, we have 2 dates identified for our next meeting in late June. Do you want to just, you might toss out which dates we're thinking about?
So we're looking at June 27th, which is a Wednesday. This would be at Cheryl Guchala. She would be
it's in Montmartre Terrace, the Primera.
hosting for us, yes. That is between 1 and 3 p.m. And the next date is June 28th. That is the following Thursday there, 3 to 5 p.m.
What was the first one?
The first one's the 27th.
Of June or the 28th of June?
Correct. So it's a Wednesday, Thursday.
So
it'd be 2 days.
Nope.
No, we're
just-
giving you a choice. Yeah, so asking you to pencil those in, and then Priscilla's going to send a survey saying, just asking which one's best for you, but we just wanted to let you know that those are the 2 dates we're thinking of.
20th, 27th is the WISHA Rural Health Conference at Lake Chelan. I don't know how many folks are involved.
Probably the 28th might work a little better.
I'm thinking the 28th.
Anyone else?
3 to 5.
3 to 5, yeah. I'd be up on Montlake Terrace. Okay. So why don't we pencil in the 28th? We'll still send it out because I know about half the people aren't here today, and we want to give them an opportunity to chime in also. And also, at this point, I want to open up the conversation to public comment, to see if there's folks who had questions or comments on things we talked about before we wrap up. John, particularly you, I know you've got a perspective from L&I about cost savings and things like that. Anything that you guys might have data on?
I don't think we do have a lot of data. There's a lot of, when I started digging into it initially, there was some confusion over do we pay for it, do we not? It's very limited. The scope of type of provider and the rules are kind of onerous. So we really need to look into it a little bit deeper ourselves.
Okay, that would be great. I mean, I think the more data, the better for all this. Great. Anyone on the phone or on video that wanted to chime in here?
Hi, this is Leslie Emmerich. I just sent a note to everybody, but I did see a presentation last week at the Home Care Association of Washington, which is mainly a home health association, on lean management and healthcare using technology and telehealth to maximize efficiency and improve patient outcomes. It was literally jaw-dropping, some of the technology that they were using and some of the data that they've had showing reduced readmissions. And I thought that it would be really valuable for this group to see that presentation. So I did tell the gal about you, and I have put her name and contact information into the chat here.
Great, thanks. So Leslie, I think there's 2 options. One is if you wanted to just summarize what you learned next time and share it with the group. The other is if this person would be willing to talk. Oftentimes it's easier for people just to summarize things.
Yeah.
So if you have the slides and we'd be willing just to kind of highlight things in about 10 minutes, that's great. Otherwise, I will also reach out to Jenny.
Yeah, I think it'd be better to reach out to her because she's got a really nice presentation on this with slides and a little video and that sort of thing. And I think if you said she had 10 minutes, that she'd be fine doing that for you.
Great. All right, I will give her a call. Great. Thanks, everyone. Anyone else? Last comments? Great. Well, we'll end a couple minutes early. And thanks again to Davis Wright Tremaine,
Thank you.
Miriam, and your colleagues.
Your host.
Okay.